So first of all, I want to thank all of you guys. You put together a powerhouse of Zoom calls and webinars over the last few weeks, and I've called into a lot of those, and it's really a remarkable job. So congratulations, and I hope we'll continue that once the crisis is over. And I was looking through the audience. We have people from Tanzania. We got Miguel from Spain, who was just here a few months ago. Massimo Balsano from Italy called in. It's quite late for him over there. We have Nick Hernandez, who was one of our fellows, and many others whose names I saw. And so again, thank you. Thanks for being here. I want to talk to you about MIS-TLIF, and I know you guys want us to go at each other, and maybe we will. But we've shared a lot of meetings together, and so far we've been able to be respectful. But maybe we'll change that today. We'll see. So my disclosures, I'll try to be as unbiased as possible. Now I want to start with a slide, and I know we want to show cases. I'll only show a few text slides, but basically this is really the summary of the whole presentation today. And I put this up here because I think it is important to kind of summarize the particular advantages, disadvantages of both procedures. I think at the end of the day, and I know Juan will agree, you got to be able to do both procedures. So the challenge is to figure out which patient is going to do better with which procedure. My big biases and my big point is that the main difference between the MIS-TLIF procedure and the lateral approach is the quality of the decompression. With an MIS-TLIF, you have direct visualization of the thecal sac, the nerve roots, to get direct decompression. With an MIS-LIF, XLIF, OLIF, or whatever you want to call it, you're counting, unless you add extra direct decompression, which you can, but doesn't really make sense, but you're primarily relying on indirect decompression. So at the end of the day, you got to figure out in your patient beforehand, is that patient going to be well served with an indirect decompression, or do you really need direct decompression? That's the bottom line. So essentially, we could just finish the talk here, but I'll go on because I have more time. I think that there are a lot of data showing that MIS-TLIF is a very safe procedure if you've done it a few times and you're comfortable doing it. It maintains lordosis. You know, it's not a lordosis correction procedure. So you got to select the right patient. But if you do it at the right patient, you can maintain, you can even gain a little bit of lordosis. But if the main goal of your operation is to restore lordosis, then MIS-TLIF is not the right operation. The anatomy is not as important in terms of iliac crest, the muscle anatomy. It is very important, though, if you do a lateral approach. The fusion rates are generally very high. It's single-stage surgery. You can totally navigate it with the lateral surgery. That's very difficult to do. And now we know Mike Wang's data, and there are some other surgeons who do more and more of these procedures awake. But even if you do it with general anesthesia, a lot of these patients go home the next day. And then with lateral surgery, I'll let Juan go into this more. But what I mentioned here are really the main advantages that I see with the MIS-TLIF procedure. So you got to figure out for yourself, are you like a wiggle guy who kind of does indirect decompression, or are you a true German surgeon who relies on direct decompression? So, and this is the only paper I want to show. Again, indirect decompression, you got to be aware, if you rely on lateral surgery, you got to understand the patient's anatomy and what's causing the patient's symptoms. You got to look at the lateral recess stenosis. We know that lateral surgery doesn't work very well for lateral recess stenosis. Facet joint degeneration can be a problem. You can't rely on indirect decompression in patients who have really a severely degenerated facet. Patients with very severe lumbar central stenosis, same thing. You can't necessarily rely that indirect decompression is going to do a good job. However, if you do direct decompression with a TLIF, MIS-TLIF procedure, you can look at the nerve roots, you get a beautiful decompression. Now, and we just published this, there's about a 10% incidence of failure of indirect decompression. So those patients where you do lateral surgery, and you have to take them back because they failed your operation, you got to do direct decompression. The first case I want to present is a 75-year-old gentleman, and this is my understanding is that this is a very interactive, so if you have any questions, concerns, or feel free. So this is essentially a patient who comes in with low back pain, leg pain, equal 50-50, numbness, tinglings, tingling, no bowel bladder incontinence, otherwise a relatively healthy retired dentist. Left EHL weakness, so he's got a neurological deficit. Let's look at the MRI scan, and this is really, so you know from the clinical picture, the patient probably has mechanical back pain and neurogenic claudication. Now you look at the MRI scan, so he's got central stenosis at L4-5, he's got pretty significant spondylolisthesis. And then I always look at the foramen, and the best way to evaluate the exiting nerve root compression is by looking at the parasaddle T1 or T2. T1 is usually better, but here you can see it nicely on the T2 weighted. You can see on the left side, there's compression of the exiting L4 nerve. On the right side, there's even more severe compression of the exiting L4 nerve root. So you got to take that into consideration. Now you got to ask yourself, is this patient gonna, are you going to be able to treat this patient successfully with indirect decompression or with direct decompression? Now let's look at the axial pictures here. On the axial T2, you can see there's very severe lumbar spinal stenosis at L3-4 and even more severe lumbar spinal stenosis at L4-5. And what I want to point out here, and Wendy probably knows better than I do, but he's got very significant lateral recess stenosis. It looks like there's hypertrophy of the ligament and flavum, maybe bony hypertrophy of the facet joint. So I think there's very significant lateral recess stenosis. So how do I take that into consideration in my decision-making process? Yeah, you could do a lateral surgery here. Take into consideration here, though, the muscle anatomy, the Mickey Mouse muscle, and Juan will tell you, he'll go on for hours to talk to you about that later. But if the muscle configuration is such that puts the patient at higher risk for neurological injury at L4-5. So we get flexion extension films. There's no gross instability here. And so what's the goal of the operation? I think we need to stabilize this patient. This patient has pretty significant spondylolisthesis, and he has mechanical back pain on clinical exam, which in my opinion is even more important. We've got to decide direct or indirect decompression. In my opinion, because of the severity of the lumbar stenosis, the severity of the lateral recess stenosis, and the fact that I think that this patient is really symptomatic from those, I think a direct decompression is safer. Safer in terms of the final success of your decompression and really getting this patient symptom-free. I don't think this is a deformity operation. I think this is really an operation in a 75-year-old that the goal should be to stabilize and decompress the central canal, the lateral recess, and the foramen. And then obviously in every patient, you take all these other things into consideration: bone quality, comorbidities. You talk to the patient, what's the patient preference, single stage, front, back, and so forth. So if you put all this together, in my opinion, this is a really good case for a lateral, for a transforaminal lumbar interbody fusion. You could do an XLIF or an LLIF, but I think I would still add a direct decompression in this patient, because I would not be able to promise this patient that indirect decompression alone is going to decompress sufficiently the lumbar spinal stenosis. So what we ended up doing in this patient was actually 1.5, which is we decompressed, stabilized L4-5 with an MIS TLIF, and then we did a tubular decompression at L3-4. We call that a 1.5, meaning we do a full fusion at L4-5 and a decompression at L3-4. We do that with navigation, totally navigated, and I'll show you how we do that in a minute. And this patient did very well. And we actually got a little bit of lordosis back in this patient. But again, in my opinion, this was not a deformity correction operation. Therefore, I don't really take that into consideration in a lot of these patients who are older and where the symptoms are really based on neurogenic claudication, mechanical pain from instability or from nerve compression. Now, how do I do the MIS TLIF? The workflow that I kind of developed over the years, and again, these things, it may differ. You may do it totally different. It depends on how you train, what equipment you have available, what implants you have available. I navigate all of my cases. I use a reference array attached to the iliac crest that works very well. I get a spin, and then I start with the screws first. And why do I start with the screws first? because I totally rely on navigation, and the navigation is going to be more accurate in the beginning of the procedure. If I'm an hour and a half or 2 hours into the surgery, the navigation is not going to be as accurate. So I want to put in the anatomical most crucial part of the surgery, is the pedicle screws. I want to put those in the beginning, but I will still need navigation and the same spin. I will still use that later on for the decompression and for the cage. So I'll put in the screws, then I'll do the decompression, I'll do the discectomy, I'll put the cage in, and finally I'll get another spin to make sure everything looks good, and I put the rods in. We started using the intraoperative CT scan, and then initially I would only use it to put in the screws, but then it turned out that we started using it for everything. We put in the screws, did the decompression, then we started using it for localization in other types of cases. So it kind of took over, and by now we use navigation in about 75% of our cases. The only cases, in my opinion, that don't work well with navigation are really lateral cases, because there's too much motion when you put in lateral cages. And therefore, I do my XLIF or LLIF procedures with fluoroscopy, and then I will use navigation though for the pedicle screws. So we use a true intraoperative CT scanner, which makes the workflow is a little bit easier. You get a CT scan and you're ready to navigate. This is a different case, but this just shows you the positioning of the patient for a typical lumbar TLIF procedure. I use a lot of tape. I know Juan always makes fun of this, but I think he's using it himself. It increases the accuracy of your navigation tremendously if you tape these patients down. I compare that to that thing at the airport where a lot of people, they wrap their suitcases. I would love to do that in the operating room, because that would make navigation 150% accurate, but it's hard to do, obviously. So I use the 3M tape here. I put the reference array into the iliac crest. You can navigate comfortably up to T12, maybe T11, with a solidly placed reference array in the iliac crest. I get an intraoperative CT scan, and then we start navigating right then and there. I start navigating the skin incision. So here with the probe, I determine the perfect trajectory for the pedicle screw. That means that you want to make the skin incision right here. So when you put in your navigated screw, don't have to push against the fascia, which would also decrease the accuracy of your navigation. You want to make the skin incision in the perfect trajectory for the pedicles. We use these types of pedicle screws now that have an integrated K-wire, and they're essentially a single pass, single step pedicle screw. There are a number of different companies now that make those, but we've been very, very happy with those. That's the pedicle screw has an integrated navigation system here. It has a little K-wire that sticks out. You obviously, at the beginning of the case, you have to calibrate, and then you make the skin incision, and you go straight down into the pedicle. You tap, and then you screw the screwdriver, and you can see here the pedicle screw goes straight in. Sometimes you have to tap a little bit harder. If the bone is really hard, there's also a navigated tap that's separate that you can use. But for the most part, this works really well, and it's cut down the time for each pedicle screw significantly. Now, this is an average time that's over the whole case of the whole. So this is, a screw takes about a minute or so, but if you average it out with the calibration and so forth, then it's a little bit longer. Well, and then we use navigation for everything else. There's no need now to stop using navigation and to bring in your fluoroscopy. So we use navigation for the bone graft. I like to use autograft as much as possible. So now we've put in our screws, and now we place the tubular retractor. And now I want to walk you through the procedure of doing the MIS TLIF procedure. The goal is to identify the facet joint. This shows you on the right side at L4, L5, we place a tubular retractor, and I use a 21 millimeter tubular retractor. You got to be comfortable wanding those tubular retractors. There's a tremendous wind outside. We have a storm, and I'm on the 40th floor. I can hardly hear anything. So you put your tubular retractor in, and you find the facet joint, and then there's a step-by-step procedure of really how to resect the facet joint. I identify, and I use navigation for this. I want to know where the pars is, because I want to make a cut from the inferior edge of the lamina towards the pars, and then I want to harvest the inferior articulating process of L4 for the bone graft. I do that under the microscope. This is now making the cut under the microscope, and I have a video that we put together years ago to kind of demonstrate that. Now here is the, and we did that in the model, and I just put this in here because it shows, for those of you who haven't done that, and I think there are a fair number of surgeons who call in who may not be that familiar, but you can see here now we're going through the tubular retractor, using an endoscope for visualization, but the actual procedure is done under the microscope. You see the inferior articulating process here. I want to move this bar a little bit. And then, so you see the inferior articulating process, the superior articulating process below. And so we make the first cut under the microscope with a drill. Some surgeons use the osteotome, and then you disconnect the inferior articulating process of L4, and then you remove it with the pituitary rongeur. You do the same thing with the superior articulating process of L5. The key here is to find the pedicle and to make the cut right above the pedicle. So you do that, and you can use navigation to find the pedicle. Then you remove the superior articulating process, and you can see immediately you have beautiful exposure of the disc space. Obviously, in real life, you still have to remove soft tissue, but then you have access to the disc space, and then you can get into the disc space, do the discectomy, and here in this case, we're kind of going in with the endoscope. Now, I don't do these cases with the endoscope, but I think it is certainly an option. The other thing you can see here is that if you look, you can actually look, you can look across, and that already, you can look into the foramen on the other side there. So that gives you already preview for later when you do an over-the-top decompression to decompress the thecal sac on both sides. So now here, we're again, this is using navigation to identify the L5 pedicle, to plan your cut where you disarticulate or you cut off the superior articulating process of L5. And then you can use navigation to get into the disc space. Now this patient, it would be very hard in this patient to really get safely into the disc space without fluoroscopy. So with navigation, you can get that step off, you can drill a little bit of bone, and then really make sure that you can get into that disc space, and then carefully spread that disc space open for your cage. That's the autograft bone that we use. We put that, I use expandable titanium cages these days. And then we put navigation, we go to navigation into the disc space, plan the trajectory for the cage, and I usually navigate the cage when I put it in. And that's putting in the cage through the tubular retractor. I have a video here, but I'll just show you, I think the next one shows it better here. So this is a video that we put together for the AOC, the curriculum for MIS TLIF and for MIS procedures. Once I have the disc space, I pack bone graft into the disc space. I don't find the funnels. I know everybody always says, why don't you use the funnel? I don't find the funnels very helpful. I use a bipolar, and that works very well. With the funnel, the space is so small that you never know exactly where's the nerve root, and it's essentially a blind procedure. I rather do it under the microscope with the bipolar. So I put in the bone graft.
Hey, Dr. Hartl?
Yeah.
Just so we don't get a little bit behind in terms of questions, I see some questions building up in the chat box. Maybe Dr. Razuli or Dr. Shin can ask you some right now.
Of course.
Sure, Dr. Hartl, there was one question, just going back to your 1.5 TLIF technique. They were asking, what is the rate of PJK with doing a decompression above a fusion in the same procedure?
Yeah, I think that's a good question. We've studied that. We did a biomechanical study. Actually, we did that at Juan's place in Phoenix a number of years ago, where we did decompressions in cadaver spines above a fusion, and then we did different types of decompressions. If you do your decompression through a tubular retractor, you have almost no impact on the biomechanics, meaning there's almost no disadvantage in terms of you don't cause any instability, iatrogenic instability above the fusion. I agree that if I did an open laminectomy, I'd be much more concerned. And I also don't want to get misunderstood in the way that we would do this at somebody who comes in already having a fusion, and we do a decompression above an existing fusion. I think that is also not necessarily a good idea. But if you do 2 levels at the same time, and as long as there's no movement on flexion extension films, I think you can do a decompression and fusion at one level and a minimally invasive decompression at the level above. We're currently studying that in patients, but from a biomechanical standpoint in the lab, we were not worried about the impact of that procedure.
Roger, that was a great presentation. One of the questions that we have here is, do you ever get x-rays or another CT to confirm the placement of the cage after you navigate that?
Yeah, we get, and I don't know if I have still time, but I do that. That's the next thing that I would do. After the cage is in, I always get a scan for sure.
Okay. And do you find that with the navigation, when you're cleaning out the disc space and you're doing the shaving and the end plate prep, does that motion throw off the nav at all, or is that still within the margin of error for the navigation, do you find?
The accuracy is a little bit less, but at this point, once you're under the microscope, you look at the dura, you're not totally relying on navigation. The navigation becomes more like a piece of the, of the whole equation. When you put in the pedicle screws, you don't have any choice. You have to trust it 100%.
Right.
When I put in the cage, if I realize that it's 1 millimeter, 2 millimeters off, that's usually fine. That has no impact.
Great. Well, you definitely still have time, so please keep going.
Yeah. So now here we're at the point we did the discectomy. We put in the bone graft. Now in this particular video, we're using a cage. I think this was a P cage that we put in. I usually now, this was done maybe 4 or 5 years ago. I use an expandable titanium cage because if you work through a small space like here, it's obviously much nicer if you put in a collapsed cage that you can expand and then backfill with bone if you have to. So this was a P cage here that we used, but nowadays we would use an expandable titanium cage. Now we put in the cage, get hemostasis. Now we're doing the over-the-top decompression. I'm angling the tube towards the other side more, and I angle the operating room table to get that exposure under the spinous process to get really into the lateral recess on the other side. And that's what I'm doing right now. And then you'll see that we're going to look, right now there's gel foam on the dura. We'll remove that, and we'll be able to look at the dura and then really go. And there's still some ligament and flavum there. We separate that with a ball tip, with a kerosene, remove that, and get a nice bilateral decompression of the dural sac. And again, this is something, if you can get that decompression with indirect decompression, it's great. But there are a lot of cases where you're just not sure. And in my practice, I didn't want to have to tell people or patients that, well, we'll do the indirect decompression, we'll see how you do, and then maybe you have to come back for a direct decompression. In a place like Manhattan, that doesn't work. There are like 10 other spine surgeons across the street. So you better come up with a good plan and stick to that plan, and hopefully you're right with your plan. So that's why I really like this procedure for patients who I think need direct decompression. Now we take the tube out, and then you'll see we'll cover everything up. We'll get a spin, and that's the control spin at the end. And then see, we'll get a spin here. And then just to make sure the cage is in good position. And when we look at the final CT scan here, now there's a P cage, so you can't see the cage, but we use a titanium cage so you can nicely see it usually. And then after this, we usually put in the rods, and the rods you don't need fluoroscopy, obviously you can feel that and see that. So anyway, I'm gonna just finish up the procedure here. So that's the planning of the cage again with navigation. Now the navigation system I use is very nice, but in 20 years they haven't been able to come up with a cage. We still have to simulate a screw here. So it looks like a screw, but it's supposed to be a cage, okay? And then that's I want to show you this because this is where a lot of surgeons really get into trouble or think they may get into trouble. That's the over-the-top decompression of the contralateral lateral recess through a tube, okay? So now we're looking from the right side. This is L4-5 again. We're looking from the right side. That's the dura. We're separating with the ball tip the dura on the contralateral side. That's the ligamentum flavum. The contralateral ligamentum flavum. That's the contralateral spinous process in lamina. So now we're separating that, and we want to drill to get a really nice bilateral decompression. So, and that's really where a lot of surgeons then kind of get nervous because they're worried about the drill. They're worried about getting a CSF leak, a dural tear. So, hold on. So now this is how I do that part of the operation. So I protect the dura with the suction. So you got to be able to drill with one hand. And in order to drill with one hand, you got to stabilize your drill on the edge of the tube, like with every other instrument. Once you get comfortable doing that, you can drill with one hand. A lot of surgeons have a hard time doing that. And then you protect your dura with the suction with your left hand, and you drill the bone behind the ligamentum flavum. So that's the ligament, and you create a trough behind the ligamentum flavum here. Once you have that trough, the tip of the drill is totally protected from the dura, and then you can go to town. You can drill all the way down to the bottom of the lateral recess, and then with a Kerrison rongeur, remove that ligamentum flavum and get a beautiful bilateral decompression. And that is now, after we have removed the contralateral ligamentum flavum, you've got a really nice contralateral decompression, and then we'll just check ipsilateral, and that's that part of the operation. So this is just schematically showing you. So now we've got the cage in, got a nice, beautiful bilateral decompression, and then we're confirming this with navigation. You can put your navigation probe in here. We've got a nice, beautiful, over-the-top decompression. There's even a movie. I actually watched that last weekend about this. And then finally, you get your X-rays and so forth. Now with those screws, you can put in bone cement if you have to. We wrote all this up. This was just published. So we put together a curriculum for all the MIS skills, the basic skills, how to use the drill, how to use the microscope, how to fix the CSF leak and do all these things. It's all being written up now, and it's available for those of you who have an interest in that. And then you can do 2-level T-lifts. We can do T-lifts from both sides. I think Nick Hernandez is here on the call. We used to do T-lifts tandem slalom through 2 different incisions with 2 microscopes. If you have, in the good old days when we were still operating and when you had 2 microscopes available. So anyway, those are all options. You can't do 2 X-lifts at the same time, okay? I just want to point that out. And I think I'm going to finish up here. I mean, I've got a few more cases, but we want to give Juan a chance. So that's the over-the-top decompression. That's the key, the over-the-top decompression. Again, and this just goes to the point again, the MIS T-lift is a great operation for direct decompression. If you can get the same result with indirect decompression, I think X-lift, L-lift, O-lift, those are all great, great options. Or if you have a multi-level case maybe, or if you have to do the X-lift higher up, and then L5 is when you do an MIS T-lift, that would be the where we marry both techniques even better. But if you need to get direct decompression, then MIS T-lift is just really unmatched in my opinion. So thanks a lot for your attention, and I'm excited to hear Juan and to kind of get some food for thought here from him.
Dr. Hartl, that was great. We definitely have time for some questions, and I have a couple for you. The first being, what's your practice for accomplishing the inner body fusion? Are you relying purely on local autograft, or are you mixing it with?
Yeah, so, Avelino Parajon, who's from Spain, he may be here on this call as well. I think I saw his name earlier. But he wrote a paper with us. He was a fellow with us, and we looked at the fusion rates for MIS T-lift surgery. And the highest fusion rates you get with BMP, right? I mean, the fusion rates are like 99%. However, we don't want to use BMP because we're worried about all types of potential side effects. So the next highest fusion rate without BMP is with autograft bone, and plus minus bone enhanced, like allograft bone chips or some other bone substitutes. So what I use autograft bone, and then I may add some other materials, but I don't use BMP. I don't think it's necessary. I use it for revision surgeries, but you get 93% fusion rates based on the literature if you just use autograft bone. So I'm pretty happy with that.
Yes, sir. And is your practice to rely purely on the inner body, or do you also drop a tube on the facets and try to get a fusion there as well?
Yeah, we all do that, but it doesn't do any good. Yeah, of course, everybody does that for a number of different reasons, but if you look at films later, it's very rare that you actually really see fusion there. So I may do it seriously when I really want to do that, and I drop a tube and I go into the facet joint and I roughen it up. But routinely, I don't do that because the results with an MIS TLIF with interbody fusion overall are so good that I don't think there's a need necessarily to do this.
John and Jonathan, any other questions from the audience?
Well, we're at 300.
That's about it for now, actually. I think that's about it.
Yeah, there was one question here just about the interbody cage, Roger. Do you have any tips or tricks about when you're using these expandable devices, where that threshold is to stop? Do you have any pointers on that in terms of how you know when a good time?
Well, it's hard to. That's a very interesting question. It's really by feel, right? Because I don't use fluoroscopy, so I don't have a visual control. It's purely by feel. Once you gotta. You certainly. There's no need to overdo it with those expandable retractors. They're incredibly powerful, and obviously one of the concerns with TLIF surgery is subsidence, right? So you don't want to overdo that. So you got to be very sensible, and I go by feel.
Great. Well, thanks again, Roger.
I just want to point out, I'm sorry to Juan, he's sitting in front of the tower. That's a real tower, okay? Not what you're sitting there for.
My God, this is the mecca of neurosurgery, my friend, in the middle of the desert. I know.
Great. So next up, we have, my friend Juan Uribe from the Barrow, really the world's premier lateral surgeon. So Juan, why don't you tell us what you have to say about all this?
Okay. You need to book. So now can you guys see my screen, correct? Okay, and can you listen to me as well? Yeah, okay. So that's great, this is amazing. I can't imagine 300 guys at the same time. Ali, Koi, all you guys are doing an amazing job. I'm very excited, and at the same time, having a good time watching Roger with, showing these nice surgeries of the 80s, trying to put a little bit of navigation on it. Sounds to me like one of these old Mercedes G-Wagons that at the end they end up with navigation or something like that, like a retrofixing everything. But it's nice, because in the 80s when everything was posterior lateral, be able to put these little cages inside the disc space was a big deal, but I don't want to. I know Roger is an amazing T-leafer. He's the ultimate T-leafer probably in the world, and his outcomes are amazing. But I want to show you a different option. As Roger says at the beginning, it's not that T-leaf is taking over lateral or lateral over T-leaf. I think they complement each other. And at the end, obviously, it's a lot of dealer's choice. But I'm going to show you here. We always discuss a lot of indirect decompression. So my cases, it will show you right away if it was indirect decompression or not, and you guys make your own conclusions, yeah? So I don't need to go half an hour and telling you what this and that, but I can tell you something very good. The fact that I don't have to deal with the spinal fluid is the best thing ever. How many of you guys love CSF leaks? That's the worst thing ever. And to be honest, there is one thing that I can tell my patients. You will never have a CSF leak, and you will never have arachnoiditis. And I don't even remember when was the last time that I put a lumbar drain, So because I'm not doing any more T-lifts and all these things. So anyway, so I'm gonna show you 3 cases and see if I can go over the time. So for some reason, this thing is moving. Okay, so this is the first case you see here. It's a young male, 42-year-old male with intractable back and leg pain. On the right, you see a little bit of the spinopelvic parameters just to show all of our guys that are in the conference how important it is to have an idea, even if you don't have a 3-foot standing images, what is the global balance of the patient. So you see here, this patient has a grade 1 spondy 4-5. This is a case that all of you guys, everywhere you are in the world, you will see it. And I'm sure, based on what I see through the world, 80% of you guys probably will go with a T-leaf. But I'm gonna show you after this, you will start changing your mind. And which is interesting is that one of the big pushback that we used to have on the lateral was like, well, then you have to take the patient in prone position and put the screws and, you know, it takes too much time. So I'm gonna show you these 3 cases actually are what we call single position surgery, which is doing a circumferential fusion through the same position. So this is the first one that you see here, moving of flexion extension, 4-5 spondy, classic. This is the classic MRI of these patients. These patients wait and wait and wait until the pain become uncontrollable, and then surgery is the option. You see here on the lower part of the screen, as you see the psoas muscles, you see on this drawing how nice they escort in the vertebra, so there is no problems to go lateral through the psoas and put your implant. And then this is the CT, which shows a very clear pars defect, you know, the spondy grade 1, and obviously the loss of this height. So there is no doubt that this patient is a candidate for some kind of fusion. So the question is, you know, you guys can go in your chat icon there. What will you do? You know, I will, you know, you guys put your input there, and hopefully between Coy and Jonathan and everybody else, they can tell us what was the consensus. Again, this is a young patient with 4-5 spondy, moving on flexion extension with a back and leg pain and intractable.
Juan, can you go back to that picture?
Yes, sir. This one or this one? So I don't know, Ali or Coy or Jonathan, can you guys tell me what, because I don't have access to the commentaries. Most of the people are on the side.
Yeah, Dr. Uribe. Oh, go ahead. Sorry, John. Go ahead.
No, it looks like Juan. It looks like a lot of them are T-lif.
Yeah, 80% T-lif.
Yeah, maybe Juan, maybe an occasional O-lif, but mostly T-lif.
Actually, Juan, I'm sorry. This is Ali. Actually, one participant said it perfect. He said, it depends if I want my patient to have post-op leg pain or not.
Oh my God, that's the story of my life. Okay,
but
let me tell you. Yes, sir.
Yes. Yeah, I mean, this is a great case for lateral surgery, but this is like apple and oranges. This is totally different from what this is a great case for indirect decompression and single stage. I totally agree.
See, even the guy who, you know, I like, you know, he's such a good friend.
Pathology. It's a different pathology.
I know, he's such a good friend, but I'm going to show you, all of you guys, because I don't blame you, any of you, you know, 200 whatever guys choose the T-leaf, because it's not your fault. You were trained wrong, guys. That's the problem, you know. If I ask all the people that have been trained, they were going to say, this is the most beautiful case for lateral, like Roger is saying right now. So anyway, I'm going to show you what I did. Then you make your own conclusion at the end. I'm trying to be as most clear as possible so you see what happened, okay? So in this case, you see that we put the patient on prone position. So it's not actually on lateral position. Using here, we identify the posterior third of the, this, localize it. And then as you see here, hopefully this video run, I know that on Zoom sometimes runs on delay, but you see you mark your incision. Then you start doing your access to the through abdominal muscles. As you see here, is a very subtle, non-disrupting dissection of the abdominal muscles. I want you to notice the amount of blood that is coming through that. I don't know if you remember Roger's videos. So I want you to see how much blood is going in here. And then you go to the muscle, And then once you get into the muscle, I want you to see here, we start dilating through the psoas muscle and trying to use real-time ENG monitoring, make sure that we have the lumbar plexus on the posterior part of the dilator. Hopefully these videos are running one by one. You see here, we're stimulating sequentially through the muscle. And then once we get into the disc space, we put our retractor. And then we start doing the bone work as you see here. You go with the cup, you go with the box cutter, through and through, make sure that we get good disc and end plate preparation. And in this case, we're using a 3D titanium implant. Notice that I'm not oversizing the implant. This is very important. If you want to take one trick, how to treat spondylolisthesis with the lateral access and indirect decompression, take a look at the height of the cages. See? I'm undersizing. Why? Because I want to have the ability to move this vertebra back when I'm reducing percutaneously. You see here, you get 100% reduction, and because the ability to do that. And then you will see on the CT that actually this is before and after, before and after. I want you to make sure that you see that we're not compromising lordosis. So you don't need to do any fancy facetectomies or things. As long as you have a good cage and you work the way that it is, it will give you good lordosis. And then watch this one. So see this MRI pre-op. This is the MRI post-op. You're gonna see it side by side. So the question is, do I really need to do a laminectomy or foraminotomy in this case? I mean, this is a really good indirect decompression. And then when you look in here, before and after X-ray, you see how total reduction in a really good case scenario. So that was the first case. As you see, actually works very good, and you can have a really good outcomes. So I'm gonna go with the second case so we can have time for questions at the end. Okay, this is actually a little more interesting. This is a 47-year-old patient, again with intractable low back and leg pain. Again, as you see here, the spinopelvic parameters. So this is a very interesting patient because this is actually a well-fit women with a high lumbar pelvic incidence and lumbar lordosis. So you want to keep that. Which is interesting in this case is this patient was miserable, nothing got better. And then finally, after she failed all these treatments, you take a look in here, there was definitely one lead level that was having issues. As you see here on the MRI, so it's 3-4, bone in bone. It was giving a lot of back pain. This is the kind of patient that you want to do everything in the world before recommending any surgery. But you get at that time, then this patient actually is a great candidate for indirect decompression. And are you okay with that, Roger? This is like ideal case scenario for a lateral surgery, you know? Is back pain, intractable, with some anterior, you know, L3 radiculopathy on the anterior thigh. And then the question is, again, for all of you guys, what will you do, you know? I wanted to know, Roger, will you do T-leafing here? To be honest, between you and me, you try everything but surgery, you know? Finally, you have to do the surgery.
Yeah, listen, Juan, I mean, you know, these are all cases that are totally different from what I talked about. You know, I mean, you don't have any of the type of compression that requires a direct decompression. So therefore, these are all great cases for indirect decompression. My concern is, what's the advantage of doing this prone? You know, what if you have a vascular injury, or what's really the advantage other than it being different than you of being doing prone?
Yeah, that's a good question. No, the prone has a lot of advantages in my point. You know, obviously, that's a new way to doing it. One of them is obviously that you don't have the need to go from lateral to prone in case, for example, reducing spondys. And we cannot deny that the placement of the pedicle screws, the best position is on the prone position. We also do it on the lateral, as you see on the next case, but the most natural position for prone position is the pedicle screw, the prone position, and also the best position for navigation is prone. Lateral, as you know, you're a good navigator, in lateral, the patient tends to move more than on the prone position. And if it's someone like you, like Roger Hartl, that does not believe on indirect decompression, you have the patient right away in prone, and at the same time, you can do the decompression, you know? And
I believe in indirect decompression. I believe in it.
Oh, is someone like you, yeah,
but not in
exactly.
every case.
And then watch, and then the other one is if you listen to Dr. Lenke, for example, and you know the big deformity guys, every time you put a patient in prone position on the Jackson table, it gives you few degrees of lordosis. So we're taking advantage of that little things. And I will find it very attractive. And, you know, I love it because it's a new way to do it. And I think it's working very good. And you saw the outcomes are doing very good. This is the next one. So
Juan, I'm sorry to interrupt. This is Ali. On that last case, there was an interesting question that sometimes they ask us personally. Yeah. What percentage do you counsel your patients in terms of back pain relief from this type of treatment for this case? What if they say, what's the chances my back pain is going to improve? What percentage, or give me a range that you can counsel a patient on?
So I probably, patient like this that do surgery is less than 5%, you know. I always encourage this type of patient to do everything but surgery, you know. This is a very delicate, you have to, this patient, for example, have a great relationship with me. You know, we see this patient for more than 6 months to a year. She tried everything on the world. And then you get to a point, most of the time, my trigger point is when I have pain management team that I trust and they say they're maximized. And when you start walking into their narcotic addiction, you know? So at that point, I may say, you know, doing a surgery, like in this case, I don't think I'm really compromising too much. But that's a great question, because the last thing that we wanted is in here is to promote fusion for a discogenic disc disease. Because, you know, it's indicated also, but it has a very selective indications. Great questions, actually.
Well, can I say something real quick? Sorry.
Yeah.
I mean, this is really, and I know Juan has that also, this is really the huge advantage of working with an interdisciplinary team of you know, pain management specialists, neurologists, to make sure that you really work these patients up beforehand. And then you can say with a certain certainty that this is probably mechanical, and therefore the surgery is going to help.
And what I like, Roger, Ali, and Coy, and everybody on the call, is that all of us, we have these patients on our clinic. So I'm take a look. I'm not trying to show patients today like a butterfly, part of my butterfly collection, T10 to iliacs, percutaneous, all these weird things, you know. I'm trying to show everyday cases. You know, you can be in Africa, you can be in Australia, you can, anywhere you be, you're gonna have one of these patients coming to you, you know. So that's what I like, what I'm doing. So in this case, I saw some commentaries beginning talking about the robotics on this. So in this case, for example, we use the robotic technology. So you see here, that's one of the answers for Roger as well, why I like prone, because prone is very friendly to robotics, navigation, etc. You know. So using here, we put in the reference mark first. So the way that we do this, I want you guys to follow me, because to me, the most critical part doing navigation is actually the pedicle screws, because it's when you need more accuracy, yeah? So for putting a case lateral, you don't need too much accuracy with the navigation. You know, you can be 3-4 millimeters in medial or lateral and you're still okay. But on the pedicles, if you're 3 millimeters medial, you may be on the canal, yeah? So that's why I like to start first with the placement of the pedicle screws. So using here, we put the patient, you spin it, whatever CT you use. In this case, we're using this system that we like, this robotic system. You start making your planning of the screws are using here, which is very common sense. In this little video you're seeing here, I like this one because the interface is very friendly. You know, you're like with your iPhone, you expand it, you close, you extend the amount of the length of the screws, you go wider. And this is, I like it because you do it as you are, because, you know, things can change as you go. So once you make your planning, so you're sitting here, we first go put the pedicle screws. So the robot, you know, really help you out exactly what is the perfect entry point of the trajectory. So as you see here, you are trying to follow exactly the path that you create. Make sure that you stay on track. And once you advance, as you see here, little by little, you're advancing into the pedicle. This system, for example, has something very nice, which is in here, that is the ability to check that you're not losing too much your positioning. Then once you put the screws, I want you to notice this. So see, notice these screws. They are modular screws. And the reason that I do it is because I have to be able to leave time to do the indirect decompression. Yeah. So if I put the rods right away, then it's going to be a big problem, correct? So I put the screws just superficial in a modular way, and then I go lateral, start using the navigation, and then start going into lateral again in the prone position, same sequence that you saw before. Little by little, you get in there, you find where is the lumbar plexus, you put your retractor, you start working through it, as you see in the little inserts. So you have the decompression, you start opening through and through. Then again, we're using a 3D expandable, I mean, not expandable, 3D printed titanium cages. And then what you do is you go from the back, you put the tulips of the screw backs, and then you pass your rod percutaneous. And this is basically what you have. This is just showing the CT post-op. You see how accuracy is. You know, the screws are perfect. I don't think you can have a better trajectory than this. The cage is just enough. As you see, it's sitting very good on the end plates. We don't see any subsidence. And then this is the images post-op. So you see very nice example also when a lateral and robotics can help. Then I have one more case, and then we go over the question. So this is a little more challenging. So this guy is a 68-year-old male. So he has past history of, as you see here, hypertension, multiple comorbidities, and then he has a previous laminectomies, failed all conservative treatments. He has severe back pain and anterior thigh pain. Then this is actually their 3-foot standing images, as you see here. The patient still is on the box. So these numbers are absolutely correct. So we like it, yeah? So the challenging here is how can you keep this lordosis? So you see the MRI, this patient, very interesting, as you see here. There is a laminectomy at the lower level, 5.1 and 4.5, spondy grade 1 and 4.5, and then, you know, this proximal area degenerated. So the question on this one, are you looking here again on the CT? So you have a laminectomy of 5.1, laminectomy of 4.5, and the spondy, and then you have this retrolisthesis at the proximal part above the laminectomy. So the question is, again, what will you do on this case? So I want you guys to put your input on the text, and I see if Jonathan or Coy of Ali tell us a little bit what is the consensus on the audience. So I'm gonna show you one more time. This is the MRI, status por laminectomies L3 to S1. This is the CT. His spinopelvic parameters are on there. So this actually patient has 5.1 decompressed directly, 4.5. I mean, you can call it. You're the king of the indirect decompression. You like this one, Roger? This. I mean,
what about the foramen? You got to show us the foramen at L3.
You can see a little bit in here. You know, I mean, this one foraminal stenosis for sure, and also in here. I don't have a, you know, I cannot show you the whole thing, but. So what, and then you see here, I was just trying to highlight in here, these facets were in issues, you know, with the laminectomy, they were violating facets, and probably that's why he developed that spondy at 4.5. What they say, the audience, Coy and Ali and Jonathan?
Maybe we can ask, while Jonathan gets ready with the audience responses, maybe we can ask Roger what he would do in this case.
Yeah.
Yeah, again, you know, this patient has, you know, degeneration at 3 levels. He's got the retrolisthesis there. And there's no central stenosis. He's got foraminal stenosis. This is a good case for ALIF and LIF. You know, there's a good case. You can do, if you want to, if you have to treat L5S1, I'm not sure that L5S1 needs to be treated, but L3, 4, 4, 5, I would do two you know, lateral, and then single stage in a lateral position, L3, 4, L4, 5, LIF, and then navigated screws at the same time.
Yeah, the problem with 5-1, Roger, is fusing 3-4 and 4-5 and leaving a big laminectomy on 5-1 alone with a big fusion on the top.
You said you had a laminectomy. That's
yeah,
right. Then I would do an ALIF. You can do lateral ALIF.
Yeah.
Or you know, and then this can be treated with indirect decompression. Therefore, it's not necessary to do a TLIF here. You know, this is not something I would treat with a TLIF.
And you avoid to go to the scar tissue and messing around with that, correct?
Totally agree.
Yeah.
Hi,
but
Juan,
I think, yes,
Juan,
sir.
I'm sorry to interrupt. This is Ali. We have a very diverse audience, and we also have a lot of non-surgeons with us. Can you just very briefly, in 30 seconds or a minute, tell us what your protocol is for conservative management before performing these operations? Do you favor one over the other? Do you have a fixed number of weeks or months that you trial non-operative therapy? And this is for patients with pain and not acute neurological deficits, of course.
That's a good question, Ali. Don't forget, to me, this one is always, this is a negotiation between you and the patient, yeah? So there is a lot of different circumstances in here, but I can tell you a little bit what the standards, yeah? So I will prefer to have at least 6 months of regular non-conservative treatment that failed, you know? And the problem with this patient is he's coming from a previous surgeries, so he never got better, and actually he was getting worse over the last 6 months. So what I like to have is make sure that the patient have a really good trials of physical therapy. He tried, you know, all the different modalities of pain management, which include not only the regular medications, but also different type of injections, you know, facet blocks, on nerve blocks, epidurals, you know, all of them. And then when most of the time is when they get to the point that the pain managements are actually recommending spinal cord stimulators and all these invasive pain managements, and these patients are not getting better, that's when the surgery become an option, you know. And this patient is not that hard, to be honest, because you see he has a previous laminectomies, which he pretty much failed in terms of the structural support. You know, he developed the spondylolisthesis and then all these other degeneration. And then obviously you have to, in order for you to make the surgical plan, then you have to take into account in this case, which I want is now for the surgeons on the side in here, is that you have to take always into account the biomechanics of the construct that you're leaving, you know? Because see, for example, if I fuse 4-5 only and I leave 3-4 and 5-1 alone, this patient is gonna show up with a really bad proximal and distal failures in the future because the levels are already, you saw that CT, for example, in here, what can you do with these facets in here? You know, 5-1, the lower level is gonna be a complicated one. So I'm gonna show you what I did, okay? So my surgical plan was a L3 to S1 fusion. I was trying to do it also in single position surgery, trying not to move the patient from one position to the other one. Wanted to use the interbody fusion that gives me the most chances of fusion and more stability, the biggest cages that I can put. So that's why I decided to do an A-leaf at 5-1 and then laterals at 3-4 and 4-5, and then do a percutaneous screws on the pedicles. So this was kind of the workflow that I did. First, I put the patient on lateral, obviously. I did first the A-lift with the patient on lateral with the left side approach. And then I moved towards the lateral transpsoas, 3-4, 4-5. And then I did a navigated screws. But notice that you're gonna see a fluoroscopy machine into the case. And I usually name the fluoroscopy in this case as a sentinel. And it's because it helped me out to give me real-time information. And the reason is because when you put the patients on lateral, they tend to move a little bit, and losing your navigation is a big deal, you know, and Roger is a big navigation person. So because I want to make sure that I don't have any problems, I take one shot of x-rays just once in a while into each level to make sure that I'm not losing my sight. So this is kind of the patient A-leaf first. Here, patient is on lateral. This is the left side up. This is the lower part. The legs are right here. Head is this way. Then you see incision, and then you see the axis. And then using here, we like to use a hyperlordotic peak cages in this case, 20, 30 degrees cages. And then once the patient is on the lateral, then you go and do the lateral approach as you see, 3-4 and 4-5. And then with the patient in the same position, you see now is the floor that I was mentioned, but the screws were placed under a navigation using here. You put the screws percutaneous above and below. You know, usually these are the trickiest screws to put, the lower one. But if you pay attention, you actually can deliver a really good procedure without moving the patient. Using here a little bit of my team developing and placement, passing the rod, getting a good lordosis. This is the MRI pre-op that you remember you saw. This is the immediately MRI post-op. So using here, if you check level by level, you see 5-1, we still have good indirect decompression and good reduction on 4-5, and 3-4, that retrolisthesis that you see here is totally corrected. So you see here, actually, if you look one by one, take a look at this MRI, the next one that is gonna show up, seems like you're making the patient taller. It's so funny, you know? But the interesting thing is that you are actually, the ligamentotaxis actually is helping a lot. And you see here the pre-op CT, this is the post-op CT. You see how level by level, you open it up and fix the different levels. And which is more important is that, as you see here, you keep the patient on the box of the spinopelvic parameters. On this way, without need to do any osteotomies, anything fancy, taking advantage of the previous laminectomy, you're able to deliver what I say, a balanced spine using a less invasive techniques and trying to maximize the disc space so I can use the biggest setup to have a solid fusion. So that's my cases, but if you guys want to start our discussions and questions, I'm more than happy to answer questions and go back and forth on anything you guys wanted.
Hey, Juan, that was awesome. This is John. Hey, one of the questions that came up is, let's say you got referred a patient that, let's say, had an L4 to S1 fusion posteriorly, T-lift, whatever, but they've got adjacent level degeneration. What's your indication to, if you're doing that lateral, will you do a standalone lateral, or are you going to back that up, open everything back, and try to connect the hardware? You know, if you've got a patient that comes to you with adjacent level.
That's a really good question. And we have that question a lot of times, John, because, and I'm gonna tell you what is the trick in here. So the problem with when you're doing direct decompression and lateral is the subsidence. You know, subsidence is the worst enemy of the lateral spine surgeon. Why? Because once you subside, you lose all your indirect decompression. That's the classic patient that is doing good 6 weeks and then called miserable your office saying that suddenly the leg pain came back and she cannot handle. You take an x-ray, everything collapsed. So I'm gonna tell you what is the trick on the adjacent segment failures. If the patient is on sagittal balance, the lordosis is matching the pelvic incidence, you can go standalone, just the cage itself, and chances that that construct will survive are very good. But if the patient is a little bit off balance, you might better go and do something on the back. In that case, what we do is we do the lateral, but then we do facetectomies at that level, and then we marry to the previous construct. Because when the patient is not on balance, the instantaneous axis of rotation is a little more anterior, so it's falling where the cages are, and that is more pressure, more chance of subsiding. So that's how we handle it. And that's a great question, because, I mean, all the participants, it is very important that you don't keep creating these monsters, you know, because yes, it's very easy to go and put a cage lateral, take 35 minutes in and out, but the problem is this is gonna last 6 months if you're not really keeping up with the lordosis. And maybe Ali and Coy, that deformity surgeons, or yourself, John, can actually give some input on this.
Yeah, no, Juan, that's a great point. And I think that, because that always comes up, I think that's a very common issue that we all deal with. Yeah. And the other question one of the people had that I thought was a great question was, you know, when you're doing that, in that same scenario, is there some like percentage of increase in disc height that you think, oh, you know what, I better back this up, even if there's no mismatch in alignment? You know, like let's say if like they had like 4 to 5 millimeters of disc height, and then you ended up putting like a 12 to 14 millimeter cage, is there some threshold or percentage there in your height restoration that makes you inclined to back it up?
So this is actually a very good question also. And I'm going to tell you with something which is very interesting, you know, because the problem is all of us, we coming from the T-leafers. You know, we were trained, I was trained as a T-leafer. When I was doing my fellowship, the only interbody procedure that we had was PLIF or T-leaf. There was nothing else. And then Foley came with the, you know, with the tube, and the T-leaf start coming. So we coming trying to use, and also A-leafers, to put a huge cages, you know, very tall cages, because, you know, you do a T-leaf, you subside, and you're doing bilateral exposure, you don't care too much. You know what I mean? The patient is fusing and you have direct decompression. But if you are doing indirect decompression and you subside, you're done. So I'm gonna tell you, based on my own cases, I can tell you 90% of my cages are probably, I would say no, 60% of my cages are 8 millimeter height. 20 to 25, the rest is 10 millimeter height. I can tell you, I can count with my hands how many times I'm using 12 millimeter heights, and I never use a 40 millimeter height in my life, unless you're doing a corpectomy or something else. So what I'm trying to tell you with that is, like, most of the patients start with 4 or 5 millimeters. If you put an 8 millimeter height, actually you're getting 100% restoration of height. And that one is better, because the problem is when you're under anesthesia, lateral position, everything is loose and you can put a train on it. But then the more pressure you put on the end plates, the more chances are to subside. So my recommendation is, there is no reason to put a cage taller than 10. Sometimes I say also, if you are doing a lot of 12 and 14 cages, 2 things are happening. Or you are subsiding everybody and damage the end plates, or you're doing surgery in patients that didn't need it because this height is already too high pre-op, you know? So maybe, hopefully that one helps.
Yeah, no, that's great.
Juan, before we get to some more questions, we're going to introduce a new feature today, which is a poll. And so I'm going to launch this poll, which asks, you know, who wants to use debate? Although it wasn't really a debate, it was more of a discussion, but we'll see if, you know, if there's, you know, if people.
Oh my gosh, I'm going to lose it.
Juan, before John addressed questions from the chat box, I did have one question. You know, I was kind of surprised with how short your lateral cage was for your case 1, the case with the spondy. You know, there's clearly not much end plate contact. And I think the post-op x-ray looked a little bit more kyphotic at that segment than it did beforehand. You know, have you had much issues with pseudoarthrosis when you sort of undersize the cage in order to better reduce the spondy?
Yeah, no, what is interesting, Coy, is that I see, that's what I want to show the CT after that. When you do a CT post-op and you stand the patient, actually these things settle a little bit, you know. And you know, the other thing that you look is, when you look at the x-rays, you look an average, you know, like an average image on the end plates, you know. But when you look at the CT, you can go cut by cut and you see what is in contact and what is not, you know. And I mean, the fusion rate on laterals is super high. And now using these 3D printing titanium coated, you know, treated titanium coated ones, the fusions are amazing, you know. I mean, and actually the subsidence also seems to be less with these implants. The problem is you force application on spondy, you end up pulling the screws when you're trying to reduce, because usually you reduce, you know, 40, 50% of the spondy when you go lateral, you know, 60%, but the rest you do it with the percutaneous screw. So you don't put yourself in a good position to pull it back, then you lose it, you know. And spondies are great because a lot of the indirect decompression is just by restoring the vertebra back. Just bring it to anatomical position, then you already have indirect decompression. That's what I always say, spondies are the best case scenario for lateral surgery, actually.
Great. I see Roger raising his hand. Roger, go ahead.
Yeah, I just wanted to, what I really like about this debate is that we're really talking about different things. But it also goes back to us generally understanding that different procedures have different indications. I showed the procedure that I think is much better served with a direct decompression, and Juan does the same thing in terms of indirect decompression. And that's actually a really good thing, because it means that the surgical community has understood that different procedures serve different purposes. You can't just, you know, look at a case and say, you know, there are like 10 different ways of doing this. There's actually a better way of doing certain cases. And that's, I think, the beauty of the debate. What I would like to ask Juan, though, is, I mean, you've showed us great cases for indirect decompression. We don't see that many of those patients. I mean, the patients that we see here are older, they've got terrible lumbar stenosis, and they may have spondylolisthesis. How do you decide in your cases that you see, like an 80-year-old who needs a fusion because they've got terrible spondy? How do you do the direct decompression? Do you actually end up doing a XLIF and direct decompression, or do you actually do like a TLIF?
Well, I mean, I can tell Roger, which is very interesting. I can tell you in the last 3 years, maybe I'm not doing more than 10 TLIFs, believe it or not, is because I push too much on the technology. I sit with the patient and I tell him, if the indirect decompression doesn't work, I always can bring you back and do, decompression through the tubes and whatever it happened. We just submit the paper with, since I moved here to BNI the last 3 years of the cases, and I can tell you that the rate of bringing patients back to the OR is around 4%, which is very low if you look that you don't need to do in these old people that. But don't forget, I pay a lot of attention choosing the patient for what procedure. I still a lot of non-fused decompression. I'll do a lot of tubular decompressions. Wow. I still do a lot of laminectomy, just, older patient with, neurogenic claudication. I mean, there is no reason to fuse a patient like that, yeah? The patient, what he needs is just a decompression. So I do a lot of non-fusion procedures as well, And as you saw, the cases that I showed, I really try to pick the best for that. But that's what makes you good on this, Be able to identify. That's what I always, in America, not for the, I don't know how the international training, but in America, we have this gap of our residents, they don't go enough to the clinic. And we're trying to create this culture, because in the spine, it's just not to put a case, 3 screws and walk away. Most importantly is the decision making, when and how, And we're trying to create this new trend where we tell the residents, as much as you hate the clinics, come to the clinic, but this is when you learn how to be successful, I don't know, probably you're in the same training at Cornell, and you guys at Duke, and John in Boston, correct?
Yeah, clinic is the most important.
I don't think my residents know what clinic is. I hope some of them are on so they can hear that. But so,
they're gonna hate us. All the residents that are online, they're gonna hate us. But listen, this is for your good, my friends. Trust me.
By the way, before Coy wraps up, I'm glad that Roger won the debate as the polling showed, because he is my partner. And if he did not win, it was going to be a long day in the hospital tomorrow. So I'm glad he won the debate. Yeah, because you bring me to a freaking knife fight with a gun, You show up with that, the audience that you pull me playing like in I don't know what freaking stadium, playing American football in the middle of Colombia somewhere, no one is going to show up. And Juan, on top of that, with all those prone XLIFs, you're going to bend over and wear lead at the same time. You're going to be that like the Hunchback of Notre Dame in a few years. So, we go sideways. We go like this. That's the trick. Actually, it's a good trick for if you guys are going to start doing prone laterals. When you put your loops, if you try to look like that, you cannot go. So you have to go sideways. That way you move it and you can see it better,
So there's a request for a one-liner from both of you about robotics before we conclude. How about first Juan, then Roger, about robotics and what the future holds?
You can go, Roger.
Was that your one-liner already?
No, I mean, I'm waiting for yours, so I compliment you.
Well, I think you got to understand that robotics is part of the bigger picture. People always talk about it's like robotics or navigation. It's total. I think it's totally wrong. You got to look at the whole spectrum of stereotactic navigation. That includes active freehand 3D navigation, robotic surgery, virtual reality, augmented reality. You got to look at the big picture. If you just look at robotics alone, you're going to miss the majority of really what's out there and what's going to change what we do in the operating room over the years. So don't just focus on robotics. Look at the big picture. Yes, robotics has great indications, but it's not like one or the other. You got to look at the big picture, because you're going to marry it with augmented reality, with virtual reality, with freehand navigation. And once you do that, then you can really leverage the whole benefit of navigation.
Yeah. And from my side is, robotics, even the infantry, but I will tell it's gonna make our life easier. It's gonna be more consistency, and what it's gonna do is it's gonna raise the bar of everybody else. So in other words, is we don't, you know, people can put screws freehand and all that things, but and then with the robotics, you don't need to be the superstar, amazing surgeon. Actually, everybody can put a decent screws and getting a regular average results, which is what we want. So basically, robotics, when they get to the point, they're gonna raise the bar. The problem is too early. We are the early adopters, yeah? Just think about the first generation of the iPhone, you know, or the T4 car. You know, now we're riding Teslas, but if we were not riding the T4 on the 1930s, we will never be driving a Tesla nowadays, you know? So I think it's something that we can try it, grow it together, and put it where it should go. And, you know, Roger is the best person for this because you embrace the navigation. Just remember navigation 12 years ago. It was like the monkey in the room, correct?
Right.
Well, Juan, you might be in a Tesla, but I'm in a Kia, but that's okay. So, you know, on behalf of the other faculty hosts, I'd like to really thank the two of you for joining us today and sharing your insights. For the, you know, we held strong at 300 participants until really about 5 minutes to the hour. For the 235 people who are remaining, just another reminder for Tuesday's session with basically the leaders of all of the major spine societies and a panel discussion on how COVID-19 is going to affect spine education. And then also next Thursday, we have another exciting lineup with Dr. Jim Harrop from Thomas Jefferson and Dr. Karina Zigarakis from Stanford University. So we couldn't do this without all of you logging on, you know, once, twice a week. Really appreciate it. And until Tuesday, thank you, and we'll see you soon.
Thanks.
Thanks very much, guys.
Thanks,
See you
everyone.
soon. Thank you.